All right, we're going to go back on the record now. Cross-examination.
Good afternoon, Mr. Einhorn. How are you? Good. My name is Dave Hackett for the Commonwealth. I'm just going to go over a few questions for you. Pull it a little bit closer. Is that better? Okay.
You just promised a few, right?
Well, see what the definition of a few is. Regarding, when we talked, you spoke earlier about the proposal for the health reimbursement accounts. Is there any analysis that you have of what the average current out-of-pocket costs are for, on an annual basis for PSCOA members?
No, as I said during my direct testimony, I know that information is available through the data at PEBTF, but and I know I was asked that about generally in PEBTF, and I could not relay that because I just don't have that information with me.
Okay. And if that number was lower than $600, would you think that then you would reduce your proposal that it should be in line with a lower rate of what their out-of-pocket costs are?
That would be a viable argument, yes.
Regarding the outline of regarding the eyeglasses and frame allowances, those, what is the Teamsters agreement that you manage? How often are you allowed to get reimbursed for the cost of frames under that plan?
Generally once every 24 months. However, exceptions are made for medical conditions, and then it can be as early as 2 or 3 months, depending upon the medical necessity of it.
And have you done any analysis from the changes of the increased reimbursements, changes that would be made to your plan of what the cost would be, the anticipated use, and what the additional cost would be to PEBTF related to those changes?
Specifically with regard to...
Let's take the lenses first of all the eye care changes that you proposed for the frame allowances, you know, of how that would, and the usage of the unit, and how that would, and now that it would be 12 months rather than 24 months, and the increased payment that would be provided, any outline of the cost that would be added to PEBTF?
Well, through extrapolation, it would be minimal because the vision program generally costs, as I recall from the PEBTF actuary analysis, $4 per employee per month. So if you are doubling that for the PSCOA members, and the PSCOA members represent 1/7 or 1/8 of the PEBTF total membership, then the cost could be minimal. It could be maybe an additional $1 per employee per month overall to the PEBTF.
Okay. Do you have that retirement proposal? Where is that? And I believe you stated that you basically wrote the proposal related to healthcare changes. Is that right?
Yes.
And then there's a proposal to provide for health benefits for retirees upon completion of 15 years. Is that correct? Would there not be any requirement with regard to age, and it's currently, I believe it.
David, to be fair, I said I primarily wrote the proposals. That's one I had no input in.
Okay. Okay. So you can't comment on that one way or the other.
You'll have to.
Okay.
That to another PSCOA.
Okay.
PSCOA witness.
Okay. But if the if if currently, if retirees have to reach, have 20 years of experience, 20 years of service, and be over 55 years of age, and a proposal was adopted to, the only requirement is 15 years of service, wouldn't there be increased costs to PEBTF in terms of its costs, in terms of you have people retiring earlier, and then you're still going to have to replace those people with people with corrections officers who then would also be current active employees?
Let me answer it this way. First of all, whenever you are expanding the universe of eligible participants, yes, you're going to, your costs are going to go up. Second, it would not be a cost to the PEBTF because PEBTF only administers the retired programs. It would be a cost to the Commonwealth, but not to the
cost to the Commonwealth, I'm sorry. And that would increase the sphere by having such a change.
Anytime you increase the universe of eligible participants, the logical corollary to that is, yes, your costs will go up.
And that proposal would?
If not standing alone, yes, but if coupled with the availability of Get Healthy or a similar disease management program for retirees, it could end up being revenue neutral.
Where you have to look at everything overall. But in terms of that one proposal itself, that would be a cost increase.
Standing alone, yes.
Okay.
Bill, in your experience, having no age requirement and just 15 years of service, is that common or not typical for retiree health care?
It really depends upon the employer. For example, let's take UPS, for example, United Parcel Service, 400,000 employees worldwide, 100,000 Teamsters in the United States and Canada alone. Their benefit is you retire after age 50 with, I believe it's 20 years, and you get retirement coverage for life for $50 a month for member and spouse. So it could be all over the board.
This proposal, you could be 35
Well,
if you start at age 20.
technically, yes. Logically,
How typical is that?
I don't think that would be very typical in this bargain.
Could I just,
The average age and the average length of service.
before we get spun off, let me just clarify the proposal. We're looking just to lower the years of service. We're not looking to take away the age.
You're lowering the years of service to be eligible for retiree health care, we're not talking about when they can retire.
Right.
No,
And-
we cannot touch that because under the Mello bill, we are not permitted to modify pension benefits in any way, shape, or form.
And I know Mr. Einhorn
Well,
didn't
this is a
speak to
medical
that.
benefit.
Speak to that proposal anyway.
Does the stack cover medical benefits?
Well, if you're
No, it
a
has
retired
nothing to do with it.
You can't be eligible for the retiree benefit unless you're collecting a pension.
And I would suggest we defer discussion of that proposal till the union has a chance to explain that further, all right? I know that you didn't testify about that earlier, so we shouldn't beat you up with questions about it. To educate me about something, if you will. In your direct examination, you had talked about, I think in response to one of my questions, that retirees enjoy a different level of benefit than active participants, at least in this bargaining unit.
Well, what I said was that PEBTF provides the benefits for active employees directly out of the corpus of the trust.
Okay.
But that is not the case with respect to retired employees. That is funded exclusively by the Commonwealth, and PEBTF merely administers those benefits for the Commonwealth.
Okay.
And that's called the REHP, or Retired Employees Health Care Plan.
Yes.
Are the benefit levels the same for active and retirees, do you know?
No, not necessarily. It depends what bargaining you're talking about and when they separate the service.
Okay.
Mm-hmm.
Okay.
Does the vicinity fund have a retiree health care benefit?
The vicinity fund does not. Other Teamster funds that I administer do.
And what's the typical retiree health benefit there for those other funds?
Age 55, full PPO coverage for member and spouse for life with prescription drug, vision, and dental. And then when the participant turns age 65.
How many years of service?
10 years of service.
10 years of service.
And they turn 65, it turns into a Medicare supplement plan.
And which fund is that, Bill, that you're talking
The
about?
joint council,
Okay.
joint council plan.
And with regard, staying with the Teamsters plan, what percentage of, for the active employees, what percentage of premium do they pay?
Virtually none, because out of, I would say, 600 bargaining units, only a handful, and I'd say less than 10, have an employee premium share. The rule, rather than the exception in the Taft-Hartley world, is there is no premium share on the front-end cost end. Or in building trades, or in the Taft-Hartley world in which I generally live, there is not.
And then there's co-pays and additional things that they have to, that they would pay
On the benefit side, yes.
on the benefit side.
Much
And
like in PPTF, yes.
so, and what is the number with regard to that of overall, you were talking before of overall plan cost, of how much someone contributes to overall plan cost.
If you break down the benefit cost allowed and separate that between what the plan pays and what the member pays, overall, fund-wide, it is between 8 and 9% on the benefit side, out of pocket, on the participant, and the rest is on the fund.
Okay. And with regards to, have you done any analysis regarding employers in healthcare plans in general for not in the public sector or in the non-public sector, of percentage that employees pay of their healthcare costs overall?
Healthcare costs overall, including premium front end?
Correct.
No, only on the back end. And we benchmark comparing ourselves to what the typical participant co-share is on the benefit side. And as I testified earlier, that's around 8 or 9%, between $1,125 and $1,150 per employee per year. And we benchmark that against other plans, and it can generally be in the range of anywhere from 8% to 14%.
Okay. And the
Overall, I mean,
Okay.
obviously, in some cases, it's going to be a higher cost share in certain pharmaceuticals, it may be 20%, but when you meld in medical and pharmaceutical all in, it's anywhere from 8 to 14%.
What does that mean compared to the $1,100? So your experience is $1,100. What's the benchmark in terms of dollars? What's that 8% mean?
It could be anywhere from $700 to $2,000.
Okay.
And your testimony earlier was that on the front end for the members of the unit, if they participate and get healthy, the front end is 6% of the plan cost, and if they don't participate, it's 11% of the plan cost.
Yes.
But you haven't performed any analysis. I think you said you don't have any figures regarding co-pays and those figures of how much the plan cost is overall for members of this unit, or average members of this unit, based on total cost, that you just don't have those
I
numbers?
do not have those numbers.
Okay. We talked, when you mentioned earlier, we were talking about the dental coverage issue. Had you requested, or familiar with something that's called a geo-access report? My understanding, that's something that identifies that someone who, if there's someone in their plan someone that's in the plan that's provided, but they voluntarily choose to go to a provider outside of the plan.